Okay, so all that's left for me to do is hand you over to our chairs for the morning, Emily and Jay. Jay will now introduce Emily, and I will leave you for the time being because I've got to go and do my e-prayer, so I shall see you guys a bit later on. All right, have a good day. Jay, over to you.
Yeah, fabulous.
Have you got your camera
thank you
on?
I have.
Okay, I will leave you to it. Have a good day.
Thanks very much, Emily. Yeah. Fantastic. Okay, thank you very much, Sumi, for the nice introduction. Good morning, everyone. I would like to welcome you all as well for this first reproductive medicine symposium running through Delta. We are going to have a whole day of educational feast delivered by some of renowned speakers in the fertility world. And we will start off with setting the scene by Dr. Emily Bailie, who will be talking on the epidemiology and evaluation of subfertile couple. It's my privilege, and I'm very delighted to introduce Emily, who is who is our first suspect trainee, which we have started the suspect training program in Derby in collaboration with Care Northampton, Dr. Ali Richardson. And it was incredibly easy to select, to have Emily with us. And she's really hardworking. She's very good academically and clinically. And in fact, even she has set up this program and coordinated this while she is on maternity leave. And that is really incredible. And I always very pleased to say that, Emily is a gold medal winner of MRCOG a few years ago, and that is not easy to achieve. And that just says, what her career has been. Over to you, Emily.
Thank you very much for such a wonderful introduction. Jake, you can hear me okay? You just give me a thumbs up. Perfect. Yes. Apologies, because my husband's Bluetooth AirPods just connected, so he nearly gave me a heart attack there, so no, we should be fine. So thank you very much, Jay, for that lovely introduction. And as I said, yes, I'm Dr. Emily Bailie, and today I'm just going to give an overview of the epidemiology and evaluation of the subfertile couple. And as I said, we'll just take questions at the end. So as I said, just a bit of an overview of what to expect from my presentation today. So we're just going to be running through the different definitions of terminology that we use regarding fertility, the epidemiology, looking at the different causes for fertility, particularly in the UK, albeit this can be very different across country to country, and particularly from high-income countries to lower-income countries. Looking at risk factors for both male and female infertility. I'm going to do a little bit about tubal factor infertility because it's not covered in any of our speakers' discussions today. And then running through when these patients come through, even from a general practice and being referred to fertility clinics, what history, examination and investigations that should be done. And then looking a little bit about the sequelae of fertility and looking at the UK NHS IVF eligibility, because I'm in quite a unique situation in that I've worked in Northern Ireland, Scotland and England, and the eligibility is very different depending on where you live. So it's something that I feel quite aggrieved on, I think is probably the right terminology. So starting off firstly with fecundity and fecundability. So fecundity basically is looking at the biological capacity to reproduce, regardless of whether conception actually occurs, and regardless of whether somebody is actively trying to conceive. For example, with a woman, if they have healthy ovaries, a functioning uterus, they are considered to be fecund, i.e. they will be able to reproduce. Whereas fecundability is very different. It actually is specifically looking at the probability of conceiving within a given menstrual cycle. It's very statistical and usually expressed as a percentage per cycle. And usually we would say in the first 3 months of a couple trying to conceive, having unprotected intercourse, that the fecundability, if the woman is ovulating, the fecundability or the chances of getting pregnant in that cycle is around 25%. And this actually decreases to 15% in the remaining months. So women are most likely to conceive within the first 3 months. But very important that when these couples are coming through the fertility clinic, that when we tell them that of all the couples that are trying to conceive, if they're having intercourse every 2 to 3 days and the woman is ovulating every month, that the chances of a couple of conceiving within 12 months is 85%. Of that 15% that don't conceive in that first year, half of those will conceive in the second year. So it's why, as reproductive medicine specialists, we are encouraging people to try for up to 2 years before seeking intervention. But it's that 7.5% really are the ones that need our help and do need to be moved through for treatment for infertility. Again, I just wanted to put a definition slide of infertility. I think these are largely interchangeable, but can have subtle differences. So subfertility is the delay in conception in couples, as said, who are having regular unprotected intercourse and have been trying for at least 12 months. Infertility is the complete inability to conceive naturally. Primary infertility is for couples that have never conceived naturally. I've never had a pregnancy, where secondary infertility affects couples who have had a successful pregnancy and birth. And we are seeing a lot of patients coming through our fertility clinics with secondary subfertility, and things can change, from a previous pregnancy. I can appreciate it is very frustrating for these couples, but as women get older, we know that there is an age-related decline in fertility. There can be new infections, may it be sexual infections or from childbirth. It could be that couples have gone through sterilizations and have had reversal of sterilization. So there are lots and lots of different reasons as to why couples can come through with secondary infertility. Next, looking at the epidemiology of infertility, and it is a very, very big problem, and it is a growing problem. And the statistics will say that 1 in 6 couples worldwide are affected with infertility, denoting 17.5% of the adult population. And it's one thing that always strikes me. My husband's not medical, and as I'm going to be honest, I'm 37, and the last couple of years is obviously the age that our peers have all been trying to have children, and it has really shocked him as to how many of our friends have struggled or have needed to have IVF successfully and not successfully. And he would say, this is something that I never noted, the thought was an issue, and it's all around us. So as I said, it affects, it's not just affecting, patients from low income countries where it's a middle income and high income countries, which is indicating that it's a major health challenge globally, and fertility escapes nobody. As I said, everyone is at risk. And looking at the number of couples around the world that are affected by infertility, the literature has a very wide scope, so, ranging from 48.5 million to 186 million women in developing countries alone, which is just humongous. The causes of infertility very much do range depending on where the couple do live, and that really is denoting the different risk factors for infertility and the different causes of infertility. So if you're looking at sub-Saharan Africa, they actually have the highest prevalence of infertility, and this is largely to do with sexually transmitted infections. These patients don't have great quality healthcare, no mind, investigations, detection and treatment. They don't have antibiotics readily available to treat infections. So, and I'll talk a little bit about tubal factor infertility later on. But there are a lot of issues that are would indicate as to why the prevalence of infertility is rising. And back when my parents were having children, I think my mum had her first child when she was 24, and that's that's not the trend that we see 30 years later. Women and couples are delaying having their children for lots of different reasons. May it be that women are trying to, get on the career ladder, trying to advance in their careers. Couples want financial stability. The costs that come, with having children, are colossal, particularly with, the childcare burden. And some of the reasons why people are delaying childbearing. And what's really frustrating as reproductive medicine specialists is that the education is not out there. We have very, intelligent women who are saying, I just didn't realize that fertility, my fertility was going to delay with increasing age. We are seeing, our patients are increasingly more obese, and we know that raised BMI does affect your ability to conceive. And we are seeing more women with medical problems coming through, particularly in the obstetric clinics. You're seeing very high risk patients who, for example, with heart conditions or cystic fibrosis, these patients that may not have previously, survived up into the age of reproductive age, but these patients are wanting to get pregnant. And as I said, they bring their own issues and health concerns and fertility challenges. We're finding that there's a decline in sperm counts, and that can be for lots of different reasons, increased smoking, alcohol, different, exposure to different environment pollutants. So as I said, let me see now, why is this not letting my slides move on? So nextly, looking at the actual prevalence of infertility, and I thought this was a really nice study done by Feng and team, that they looked at the epidemiological characteristics of infertility, and they spanned their project between 1990 and 2021, and then they actually went on to do a 15-year forecast of what we can expect for the prevalence of infertility, and they looked at the age standardized prevalence ratio for male factor infertility and female factor infertility. And what they found, as you can see nicely from the graph A for females and for graph B for males, is that the rate of infertility for both males and females is increasing. The age standardized prevalence rate for females was 2,700 women per 100,000, and for males this was 1,300 per 100,000 males, which, as said, is a very, very high figure. Next, they then looked at it, looking at across 204 countries that were included in the study. And what they did find, as said, if you're looking at A and C, this is looking at changes of female and male infertility cases. So as said, the red and the dark red are where the prevalence is significantly increased. But what they have found is that India was ranked first for both the prevalence of cases in both male and female infertility, and that was followed by China and Indonesia. So as I said, ranging between low, middle and high income countries. And then what they have found as well, when they're looking forward, that their study projects that the global rise in the age standardized prevalence rate for infertility between 2022 and 2036, they're projecting a global rise, and a lot of this is to do with the rise in the population. And what they basically concluded is that this trend highlights that the pressing necessity for better strategies concerning prevention, diagnosis and treatment, particularly in the low and middle income nations. We need to strengthen our healthcare infrastructure. We need to enhance the access to high quality medical services, and particularly in the low income countries. And it also is really important that we do increase the awareness of infertility, because as I've said, we are seeing that the information is not out there. Women in particular are not realizing that age is a major risk factor for infertility, and one that unfortunately we can't reverse. So looking at actually pregnancy itself, so for pregnancy to occur, every step of the human reproduction process has to happen correctly. And the steps of the process are that one of your two ovaries has to release a mature egg, and the egg needs to be picked up by the fallopian tube. The sperm need to be able to get through the cervix and the cervical mucus. They have to travel up through the uterus into the fallopian tube, where fertilization actually occurs in the fallopian tube. Then this fertilized egg will travel down the fallopian tube and make its way to the uterus, where it'll then implant into the uterus and grow. Infertility is basically when this normal process of fertilization and implantation either does not occur or it is impaired in any of those steps. So basically it can go wrong in lots of different times and lots of different ways. Next, looking at the etiology or the causes of infertility, and this slide really will denote the causes of infertility mainly in the UK. And you'll find that looking at the causes of infertility in different continents, it will be very different, but focusing on the UK, the main causes include male factor infertility, which is the blue box, denoting 30% of all cases. Ovulation disorder, which is 25% of all cases, tubal damage and uterine damage. But it's also very important to note that unexplained infertility affects 20% of the couples that come through our clinic. And what I often will say to these couples is that, yes, I don't have a cause for you today that as to why you haven't been able to get pregnant, but reproductive medicine is such an amazing field, and that it moves on so quickly, and that I wouldn't be surprised that in 10, 15, 20 years time, that for these couples that we had unexplained infertility, that actually we may have found a cause as to why. We just don't know it yet, but we may have found a cause in the future. So firstly, looking at the female causes of infertility, and ovulating disorders, as I said, make up for 25% of the patients that are coming through. And we could break that down depending on what the hormone profile shows. So I am going to only touch on this very, very briefly, because we are very fortunate to say that we have experts going to be covering, firstly, hypogonadotrophic, hypogonadal, anovulation, basically where all the hormone levels are low. And Dr. Roger Stanworth, one of our endocrinologists, is very kindly going to cover this topic for us. And then we've got when the hormone levels are all normal, so normogonadotrophic, normoestrogenic anovulation. And we're very privileged to have Professor Adam Balin going to be covering PCOS, who's leading in the field of PCOS. If you need to know anything about PCOS, he's the man to talk to. And then we've got hypergonadotrophic, hypoestrogenic anovulation, and it's we're having a wonderful presentation from Dr. Joanne McManus on premature ovarian failure, and Joanne has said there's nobody who knows more about this, about hormones and managing POI than her. And then we've got, as I said, hyperprolactinemia, which will be covered in the talks as well. So as I said, ovulation dysfunction can range very widely. But as I said, female causes for infertility include endometriosis, which is basically where the endometrial lining can grow outside of the endometrium, and it can grow in the pelvic sidewall, giving women chronic pelvic pain. But it can also affect infertility in that, it can cause endometriomas. They can get tubal factor infertility from the tubal damage from the endometriosis. And again, we've got Professor Ammer from Derby, who's going to be giving us a wonderful presentation about endometriosis. And as I said, I've worked across many different places in the UK, and I've never seen pelvises with endometriosis that Prof. Ammer can tackle. I can't see anatomy, and it's incredible. So we're very fortunate that he's going to give a fantastic talk on endometriosis. Pelvic adhesions, namely from PID, STIs, is a major cause of infertility, particularly in the developing world. Tubal blockage, again, in keeping with PID, hydrosalpinx, and women who have had previous sterilisation procedures, which I will cover today. And then I said uterine anomalies, for example, fibroids, congenital uterine anomalies, septums, which Professor Jay Prakashan, who will cover that today. So looking at the risk factors for female infertility, and as I said, up to 20% of these cases are deemed unexplained infertility, but there are lots of different male and female risk factors that will increase a couple's chance of coming through with infertility. And the vast majority of them, as you can see, are modifiable. And firstly, I said, so age over the age of 35, albeit it is very important to know that we do still have women under the age of 35 who are coming in with age-related decline in their fertility. Smoking, obesity, excessive alcohol consumption, sexual history. So it said, namely the treatment of sexually transmitted infections, stress, excessive exercise, and environmental factors. So age is one of the only non-modifiable risk factors for infertility, and unfortunately, there's no treatment option to counteract that. Once your fertility decline to do with their age is going down, there's nothing that we can do. There's no magic treatment that we can do to try and improve, the number of eggs that you have or the quality of the eggs that you have. And as I said, that's why it's really so important that the education is out there for women to be aware that fertility does decline with age. And as I said previously, couples are having children later, and that we see, women in their sort of mid to late 30s, it's a bulk of our workload coming through the fertility clinics. And really it's from the age of 35. So you can see women up to the age of 35, their risk of infertility is as low as 9%. But then once you're between 35 and 39, that really significantly rises to up to 25%. And as said, when you're over the age of 40, it's up to 30%. And as I've said, it's largely to do with the decline in the number of eggs that are available. Women are born with all the eggs at birth that they're ever going to have. You don't at the moment, the thought process is that, you cannot, create more eggs, and that number of eggs declines, particularly from menarche. And the rate of follicle loss then does decline significantly once you hit your mid-30s until the age of menopause. But as I said, the quality of the eggs also does decline. With increasing age, women are at risk of pregnancy complications, increased risk of miscarriage. And I said, often these women will have the other comorbidities that need to be taken into consideration that can affect their fertility. And yes, spontaneous conception decreases with age, but also the success rates of IVF also declines with age. So. And this is a nice infographic from the British Fertility Society that shows that as women, as I said, you can see in the purple line quite clearly that the age-related decline does occur much earlier in females than it does in males. So moving on to the next risk factor, which is smoking. So cigarette smoking has been consistently shown to be significantly detrimental to fertility, both for both males and for females. Studies have shown that women who smoke are at increased risk of delay of becoming pregnant, and this is for both in primary and secondary infertility. And it also shows that women who smoke during pregnancy have significant risk of complications, including low birth weight, premature birth, stillbirth, and infant mortality. But what is reassuring is that if women do stop smoking, that there appears to be some degree of reversibility. It may not improve right back to women, if you've never smoked, but it's really important that we have women who are coming through trying to conceive saying, look, smoking is such a major risk factor, and if you stop smoking, things may significantly improve. And it's all to do with toxic compounds that are found in cigarette smoke, including cadmium, because it's these toxic compounds are also found in the follicular fluid from the ovary. So as I said, it's making its way to the ovary, so it is very important that women are aware that it will affect their ability to conceive. And as I said, menopause is more likely to occur earlier, and that could be up to 4 years earlier in smokers. And it's all to do with its detrimental impact on the ovarian reserve. So, which is why, as I said, particularly, I know in England that if you're a smoker, you automatically are not entitled to your free cycle of IVF. But if you stop smoking, then as I said, that entitlement is reinstated. Where is my slide? Oh. Next, moving on to obesity. And a raised BMI, especially when your BMI is over 30, can negatively impact fertility. In several studies, it has been shown that the risk of infertility is 3-fold higher in obese women compared to non-obese women. And it affects not only natural conception, but also if the woman was to go for IVF. And as I said, it's been shown that the chances of actually getting pregnant are reduced by 5% with every BMI over 30. So as I said, if your BMI is 31, it drops by 5%, 32, it drops by a further 5%. So as I said, it is really, really important that these women are educated as the importance of getting their BMI into a normal range, which I appreciate is no mean feat. But as I said, we're finding increasingly that our patients are availing of the injectable medications to try and improve BMI. So as I said, it means that more women are being able to reach their eligibility. It is a growing problem globally, not just in fertility, across the health service, in general, and in obstetrics, our patients are increasingly obese. But as I said, the financial burden on the NHS of raised BMI is colossal. And in 2016, it was found that 1.9 billion adults were found to be overweight, and a further 650 million patients were found to be obese. So it's a colossal issue for the health service. Looking at the different risks for BMI, as I said, the chances of having natural conception are reduced if you're overweight, and a lot of that is to do with ovulation dysfunction. There is a very close link with raised BMI and polycystic ovarian syndrome, and showing that if these, and I'm sure Prof. Bailie will touch on this, that if we tell women if they lose between 5 and 10% of their body weight, they could actually completely normalize their endocrine profile, and these women can spontaneously conceive without any input. So as I said, natural conception is absolutely affected by raised BMI, but also as I said, the chances of IVF success rates are significantly reduced for women with raised BMI, and actually can be up to a 20% reduction in live birth rate. We also, when we're thinking of IVF and thinking of the safety of actually doing IVF, raised BMI, being able to perform, in a collection of women who have raised BMI is, offering sedation. There's anaesthetic risks. There's risks, instead of the actual procedure of an egg collection. So that's why, I said, particularly in the NHS, the BMI it has to be less than 30. And it's to do with, keeping the patient safe, but also, as I said, improving the success rate of the IVF. These patients are at increased risk of miscarriage. So once they're pregnant, the general population is 25% chance of having a miscarriage, but it can actually be up to 40% for women who are overweight. And also, when they do continue on to get pregnant, there's significant pregnancy complications, risk of hypertensive disorders, preeclampsia, gestational diabetes, and need for operative delivery and cesarean section. And as I said, the labour complications can include things like, shoulder dystocia, metabolic syndromes, and prematurity. But equally, as I said, raised BMI is not the only problem that we're finding. They're not the only patients that are coming through our clinics. We are also seeing lots of women with low BMI, and the optimal BMI for conception is between 19 and 25. BMI under 19, we find, can disturb their hypothalamic pituitary gonadal axis. Now, that is not to say that every woman with a BMI of under 19 is at risk of infertility. There, if you're naturally lean and you're having regular periods and everything is fine, but it's more when we see women who haven't had periods, or they're having very infrequent periods, then we could likely attribute their low BMI to their infertility. And it's because low body fat has been shown to reduce estrogen levels, which again can affect ovulation and make it difficult to conceive. A very good friend of mine is a very active, has always been very sporty, and struggled to conceive. And she, as I said, over the last 10 years had very few periods. Now, she has been lucky to have her family, but is now significantly osteoporotic and has just broken her hip for a second time at the age of 37. So as I said, low BMI is a significant issue, not only for female reproductive health, but as I said, it affects fertility. Women with low BMI have been shown to have a less receptive uterine lining. They're at increased risk of miscarriage. They can have nutritional deficiencies, which again can affect their fertility. And it's really important that with these women, we support them. As I said, low BMI, what we tend to find is that if we improve their nutritional status, if we increase their BMI to the point where they're having, they're restoring their HPG axis, they're having periods again, then these women should be able to spontaneously conceive. But equally, as I said, it is very important that we support these women. We include dietetics, we include counselling, because as I said, they should get it there. But as I said, it's being very mindful about that, particularly, depending on the cause for their low BMI, whether, as I said, there's a mental health issue or if there is an eating disorder. So in the management of BMI, as I said, any women under the BMI under that should be 19 with a history of intense exercise regime or eating disorders are likely to develop hypogonadism, and Dr. Samworth will tell you an awful lot more about that. But as I said, 87% of them should regain regular ovarian function with just improving their BMI. And equally, as I said, women with a raised BMI with an ovulation can improve ovulation by losing up, if they lose up to 10% of their body weight, they should be able to restore their ovulation. Next, looking at the effect of alcohol on fertility. And as I said, alcohol consumption does appear to affect fecundity, or as I said, patients getting pregnant. And again, it's patients who are considering trying to get pregnant, it's dropping the female alcohol consumption is definitely something we would recommend. Compared to non-drinkers, female alcohol consumption is associated with lower fecundability, and that was looking at a meta-analysis based on 19 studies. And there does appear to be a dose-related response with alcohol and reduced fecundability, so that for every unit of alcohol that you're finding that the fecundability does drop. So as I said, it's a reversible risk factor, and as I said, we tend to find if if the women reduce their alcohol intake, that they may find that their fertility does improve. And as I said, you can see from this graph that how, as I said, with increasing alcohol intake, you can find the relative risk of, as I said, looking at the relative risk of corresponding alcohol intervals with fecundability. So increasing alcohol does reduce your fecundability. Next, looking at exercise as a risk factor for infertility, and that it is important that we do say that many women do regular exercise, and exercise is very important when it comes to infertility. As I said, in particular, it's very important for health. Every woman, it is recommended that people do, between I think it's about 30 minutes of exercise 5 days a week. As I said, it is very beneficial for mental health. But as I said, excessive or vigorous exercise could actually negatively impact fertility. And there's been lots of different studies that have looked at exercise, and we find that women who do physical activity every day, particularly vigorous exercise every day, are more than 3 times likely to have fertility problems compared to somebody who does less exercise. And as I said, this particular study looked at quantifying that, and they said for women who do over 60 minutes of exercise per day, the relative risk was 6.2 compared to someone who didn't exercise. But equally, these studies need to be looked at very closely, because they're not always they don't always agree. And so as I said, there's another study that showed that if women do 30 minutes of exercise a day, that actually it could be beneficial for ovulatory infertility, particularly linked to BMI. So as I said, it's making sure that when you're looking at physical activity, asking them about their menstrual history. So as I said, if they're finding that their physical exercises has caused them to not have periods, and that's when the exercise has become an issue. But if somebody's having regular periods, and that's very important to take that into consideration before criticizing their exercise regime. So looking at stress with regarding infertility, and obviously infertility and stress do go hand in hand. And every person who comes through our fertility clinic, when you decide you want to have a baby and it's not happening, it is an exceptionally stressful time. And healthcare professionals saying to women, oh, you just need to manage your stress or reduce your stress. I can only imagine how upsetting and frustrating that is. People can't just turn off stress. But it has been shown that high levels of stress can affect fecundability. Now, if you find no other reason for infertility apart from the woman is stressed, it is unlikely that is the sole reason as to why this person hasn't got pregnant. But it can affect, and it's important because it can affect ovulation, it can affect libido, and it can, there's studies that have shown that it can affect the embryo implantation and oocyte quality. But as I said, it's very, very important that we kind of help guide patients on how to manage stress, thinking about, what do they enjoy, different pastimes, considering sort of yoga, meditation, deep breathing exercises, mindfulness. But as I said, it's going to be very patient specific. But as I said, I wouldn't be the first healthcare professional to have the experience of, once a patient is put on a waiting list for IVF, when they are thinking, right, something's being done, we're going to get a baby through IVF, and then they spontaneously conceive. So there definitely is, stress does have a part to play. So looking at tubal factor infertility, and tubal factor infertility accounts for up to 33% of all infertility. Obviously in the UK, I think that figure is slightly lower, but when we're looking across the globe, particularly in sub-Saharan Africa, it could actually account for up to 85% of infertility. And as I said, there's multiple different causes for tubal factor infertility, but the most commonly being sexually transmitted infections that become pelvic inflammatory disease. But endometriosis can have a significant factor on tubal health. We have patients that would be coming through who have had previous tubal surgery. Say, for example, if they've been previously sterilised and they decide that they do want to have more children, obviously the tubes will be significantly impacted from that. And then obviously conditions like hydrosalpinx can affect the tubal health. So sexually transmitted infections are the leading cause of tubal factor infertility, and the main organisms that are implicated in tubal factor infertility are chlamydia and gonorrhea. But there is increasingly evidence that other organisms are coming into play for tubal damage, including Mycoplasma genitalium and Trichomonas vaginalis. And in particular, if you have Trichomonas and co-infection with chlamydia, you actually are finding that they sort of, when they coexist, they can perpetrate an increased risk of upper genital tract infection rather than just chlamydia on its own. Now, we don't, I know in the units that I've worked in, we don't look for anything apart from chlamydia and gonorrhea, but this may change policy in the future, that it is important that there are other organisms that need to be considered. And basically what these organisms do, how they affect the tubes, is that they cause salpingitis, or inflammation of the tube, which will then go on to cause adhesions within the tube. And so, as I said, looking at PID, so pelvic inflammatory disease, is basically when this is an infection of the uterus, the fallopian tubes and ovaries, and it can lead to scarring and damage within the fallopian tubes, hindering their ability to function properly. The ascension of microbes into the upper reproductive tract occurs as a result of the disruption of the normal protective barriers in the lower reproductive tract that you can see in figure 1. So it's you get the cervical infection first, and the initial infection within the cervix then moves to involve the endocervical canal, and it breaks down the mucus plug. That mucus plug is so important, to act as a barrier to try and prevent any infection. But when the cervicitis and plug barrier is broken down, then, as I said, the pathogens can then migrate further up. Women are particularly susceptible during mid-cycle when obviously the body is, the uterus is wanting to facilitate, spermatozoa to move through that cervical mucus, so that it's during that period where the uterine peristalsis to try and facilitate the sperm transport that these infections can actually be propelled up into the uterine cavity. And as I said, then it results in sort of the menstrual fluid moving up in through the tubes, and then, as I said, infecting the entire tubal cavities, moving on to then pelvic inflammatory disease. So how do these women present? They often will present with lower abdominal pain and high temperature. When we examine them and do sort of bimanual examination, you're going to find significant cervical motion tenderness, indicating inflammation in the pelvis, and they may have discharge. But what's very frightening, particularly about many sexually transmitted infections, is that particularly for women, chlamydia can often be completely asymptomatic, so they could be having significant pelvic adhesions forming, and they don't know anything about it. With PID, the management is antibiotics, and this very much depends, outpatient or inpatient, depends on the severity of the infection. I think a very good rule of thumb is if they've got a raised inflammatory markers and a temperature, then these patients should be admitted to hospital and given IV antibiotics and be treated very aggressively. Because the number of episodes of PID that a woman experiences is directly proportional to her risk of infertility. So if they have one episode, 89% of women will still go on to conceive. If they have 2 episodes, that can drop to 77%, with 3 episodes dropping down to 46%. So it's really important that they're picked up and they're treated aggressively. And as I said, but it's very important to know that the majority of women may not actually have any obvious, history of a infective event, and that's, as I said, people coming to our clinics with tubal damage, and they didn't know that they had an STI, and the damage is already done. So these are just some laparoscopic pictures of things that we may see with people with a history of PID. So as I said, the first image on the left, you can see significant adhesions between the posterior aspect of the uterus and the tube. And the image on the top right is Fitzhugh-Curtis syndrome, which is a rare complication of PID, namely chlamydia. And this is characterized by the inflammation of the liver capsule with the formation of adhesions. And these patients may present with right upper quadrant pain. So as I said, it's very important. We all, when we put our camera in laparoscopically and we do our 360 view, we're obviously firstly looking to make sure that, we haven't caused any damage to the bowel when, with our entry technique. But gynecologists are always looking up the liver to make sure that there's no evidence of adhesions with the liver, because as I said, it's important to pick that up, even for women who are not having a laparoscopic procedure for fertility. As I said, it is important so that we pick it up. So hydrosalpinx. So hydrosalpinx is basically a condition where the fallopian tube becomes distended with fluid, and it's a significant cause of infertility, and can reduce the success rate of fertility treatments like IVF. 50% of them are as a result of PID. And as I said, it reduces the chance of spontaneous conception and increases the risk of an ectopic pregnancy. And it's the thought process, particularly when we look at how hydrosalpinx will affect the success of IVF, and we will actually quote to women that if we went on ahead and did an embryo transfer when a woman has hydrosalpinx, the live birth rate is 50% reduced, which is very significant. So, because if a woman under the age of 35 success rate is 50% of having a pregnancy, that's dropped to 25% with the hydrosalpinx, and it's often to do with whatever fluid, the composition of the fluid is toxic to an embryo. So on ultrasound, you can see this sausage-like structure adjacent to the ovary, and that's a hydrosalpinx. And on laparoscopy, this image on the left is a normal pelvis, and the image on the right, you can see this is a very distended tube, hydrosalpinx. So how do we manage tubal factor infertility? Often these patients will need surgery. And as I said, the surgery is laparoscopic. May this be a salpingostomy, which is basically where we open the tube and remove the fluid and stitch it back again, particularly if the patient has endometriosis. But also salpingostomy does come with a risk of it forming its own adhesions. Tubal cannulation is basically where we do a hysteroscopic procedure where we actually just try and reopen the tubes with, as I said, passing a cannula down the tube. But often, particularly if these patients are going to go for IVF, we'd be recommending salpingectomy, which is a very difficult decision for a couple to make, particularly if it's bilateral hydrosalpinx, because once you remove both tubes, then these patients can't spontaneously conceive. But as I said, if these patients are not getting pregnant anyway, then they're going to need IVF, and their IVF rate will be boosted without the hydrosalpinx. So moving on to male risk factors. So as I said, a lot of them are very similar to females, and we will have a talk today by Neela Potter, who's going to take us through male factor infertility. But a lot of them are very similar to females: smoking, alcohol, illicit drug misuse, obesity, heat exposure. So as I said, she will touch on all that. It's very important that when you're taking a history from males that you do ask them about any previous sexually transmitted infection. You want to know about mumps, because as I said, mumps orchitis can be a significant cause for infertility. You want to know about history of undescended testicles. We would like to think with the baby checks that are being done now that this should never happen. But men that are coming through in their 30s, it wasn't definitely not as robust, so it is definitely something we're seeing. History of varicocele, the guidance has very much changed on varicocele. It used to be something that we didn't pay too much attention to, but now, as said, it is very important that if varicocele is picked up on a male with male factor infertility, then they are referred to a urologist. And as said, medical treatments, including previous history of chemotherapy, is important. So when do we refer patients? The NICE guidance would say that if a couple under the age of 35 have been trying to conceive for 1 year, that they can be referred for further investigations. But we can do this earlier in a number of different indications. For women over the age of 35, after 6 months, they can be referred through. But if they have a history of any sort of gynecological condition that can hinder their chances of getting pregnant, so previous PID, previous endometriosis, previous cancer treatment, we can refer these women much earlier. Again, and similarly in males, if, for example, a patient has had we know the risk of male factor infertility, then we can refer them earlier. For example, if they've prior cancer treatment, if we know they've previously had surgery for varicocele. So as I said, there's lots of different reasons why males can be referred sooner. When these patients are coming through the clinic, we do, the reproductive medicine history is quite thorough. I often will say to patients, I'm not being nosy. I promise these are very important questions that I need to ask. We want to know how long they've been trying to conceive, any previous pregnancies. We want to know about their reproductive menstrual history. So are their periods regular? So as I said, regular periods or irregular periods will make us think, is there an issue with ovulation? Do they have painful periods? Is this somebody that potentially has underlying endometriosis? and they previously had any sexually transmitted infections. Is this patient at risk of tubal factor infertility? Have they had babies before? Say, for example, we had a patient a number of months ago in Derby who had come through, and she'd had a second trimester loss at 17 weeks, and it was actually down to the fact that she had a uterine anomaly. She had a unicornate uterus. So, making sure that you take an obstetric history is very important as well. Contraceptive use. I'm sure I'm not the only person who has had patients come into fertility clinics who are still on contraception, and they haven't realised that they were meant to stop it, or patients that have been on the depot, and they maybe weren't aware that it can take up to a year for the fertility to resume. So very important to take that. Very important to take a sexual history. Again, I say to them, I'm not being nosy, but particularly when patients have been trying for a very long time to conceive and intercourse becomes a little bit medicinal, that actually they're maybe not getting the timing and frequency right. So as I said, I always say to women, if you're having a regular cycle, really after day 9, intercourse, regularly is very important. Important to know their medical and surgical history. Have they got chronic illnesses, that with, for example, diabetes, that needs to make sure their HbA1c is in range before we think about IVF. Are they hypothyroid? Is that a reason why that affecting their ability to conceive? Have they had cancer before? Have they had pelvic surgery like endometriosis or fibroids removed? Are they a smoker? And then moving on to lifestyle, do they smoke? Have they asking about their exercise? Are they on taking any supplements? As I said, patients will come in on very weird and wonderful things and, over-the-counter medication. So it's very important that we take a full history. When we're examining them, pelvic exam is very rarely ever needed. BMI, very important to ascertain their eligibility. Any evidence of any PCOS, or looking for hirsutism, sort of abnormal hair growth, acne. But as I said, if somebody tells you they've a fibroid uterus, you're absolutely going to want to have a feel of their tummy. Investigations, you want to do a chlamydia swab for everyone, blood test, which we'll touch on in a minute, pelvic ultrasound and tubal patency testing. And whether everybody has tubal patency testing very much depends on your trust. So the blood tests that we do are basically wanting to ascertain ovarian reserve, and this will be done looking at FSH levels, and you want that to be done early in the cycle, and I'll touch on that in a moment, because as I said, it gives us an idea of ovarian function. You want to look at their thyroid function, because that, as I said, hypothyroidism in particular can affect ovulation and pregnancy. Hyperprolactin, high levels of prolactin again can affect ovulation. You can do a day 21 progesterone to confirm ovulation, but what's really important, if a woman, for example, has a 30-day cycle, a day 21 progesterone is not helpful. You want it to subtract by 7 days. So if they have a 30-day cycle, you actually want to do that progesterone on day 23. So it's 7 days before their predicted period. If you're concerned that somebody may have PCOS, then you can do an androgen profile. So ovarian reserve, there's lots of different ways that we can test ovarian reserve. I'm aware of time, I've been waffling on. So AMH, which is your anti-Müllerian hormone, you can and your antifollicle count, or your FSH level. But what's really important to tell these patients that ovarian reserve tests are really helpful at telling us how they're going to respond to IVF, but they're not diagnostic in predicting live birth. I have lots of friends who have come to me and said, my AMH level has been shown to be low. It is not going to affect your ability to predict natural conception, and lots of them have gone on to conceive with low AMHs, but it is helpful when we're thinking about planning IVF strategies. It also does not give us any information about oocyte quality. So AMH is a hormone that is released by the follicles in the ovary. It can be measured any time in a woman's cycle. It does decline throughout a woman's reproductive lifespan, and it is a very good predictor for ovarian response. Looking at it in p moles per litre, over 16 we would say is a good reserve, and under 5 is low ovarian reserve, and it is affected by age. So if you're looking at the orange box, this is what we would expect a normal ovarian reserve to be, and as you can see, it declines with age. But women who have a high ovarian reserve, we would be suspicious of polycystic ovarian syndrome. And that makes sense because it's a hormone that's released by the follicles of the ovary. And if you've got polycystic ovaries, so you've lots of follicles in the ovary, then you're going to expect a high AMH. And you can see from the table that AMH drops with age. Antral follicle count is an ultrasound, which basically you do a pelvic ultrasound, you count the number of follicles on the ovaries, gives us a snapshot of ovarian reserve. Ideally, you would like it to be done between day 2 to 4 of the menstrual cycle when there's not a big follicle city for ovulation, but it can actually be done at any point. And again, it can decline with age and would indicate ovarian reserve. So these are some images of polycystic ovaries, so you can see all the different follicles. So in an AFC or antral follicle count, you would count all these follicles, add them together, the 2 ovaries, and gives you an AFC. And the images on the second slide is of a very fancy software called Sonar ABC, which basically is an automated process whereby it will count the follicles for you, which is very handy for women with polycystic ovaries. We have lots and lots of follicles. Follicle stimulating hormone is a hormone that's released from the anterior pituitary, and then, as I said, it then stimulates follicle growth within the gonads, and it is really important, and it's useful for ovarian function. So if the FSH is high, it would tell us that the ovaries become less responsive and that there's a drop in ovarian reserve. So if on day 2 to 4, if their FSH is over 10, we would assume that if we were going to do another ovarian reserve test, for example, an AMH, I'm just going to suspect that the AMH level is going to come back low. But a lot of trusts, particularly I think in London, they don't do AMH or AFC. They will use purely the FSH, and that is one of the criteria for eligibility for IVF. And then pelvic ultrasound is done for all patients coming through because we don't like any surprises. So first image on the left, you can see an intrauterine or intercavity fibroid, or intrauterine fibroid, apologies, but obviously we want to know about fibroids, their location, their size, and whether they're affecting the uterine cavity. Image on the top right is an endometrioma, and again, if you see an endometrioma, you're going to be suspicious of endometriosis. Image on the bottom left is a 2D pelvic ultrasound, and would give you an indication there might be 2 cavities. And then when we do a 3D ultrasound, which particularly in the trust that I'm working with, in every patient has a 3D ultrasound prior to starting IVF. And for this patient, you can see they have a bicornate uterus, and you know it's a bicornate uterus because of the shape of the fundus. Apologies. This is a uterine septum. Prof. Jay Percussion is probably shouting at me to unmute. But so if you look at the shape of the fundus, as I said, it's flat, and you can see, whereas a bicornate uterus, you would expect the fundus to be dipping down and back again. And as I said, a uterine septum, which Professor Jay Percussion is an expert on. He'll tell you all about them in his presentation. Tubal patency, there's 3 different ways that you can do tubal patency, and it depends on what trust you're in and what your funding is. You've got HSG, which is an X-ray. You've got HICOSI, which is ultrasound, and you can do a laparoscopy and methylene blue dye test. And in particular, if you're concerned that somebody, for example, you found an endometrioma on scan, you're assuming that this patient might have endometriosis, it would be prudent to go on ahead and do a lap and dye test for this patient. So HSG, you can see on X-ray, the image top left, and that's a normal HSG. You can see the dye has gone up through the uterine cavity, out through the tubes, and is spilled out the fimbrial end. The top right is hydrosalping, so you can see there's no tubal spill, but you can see the outline of the tubes. And as I said, the bottom image, you can see that the tubes must be blocked more proximally because you don't see the outside of the line of the tube. And this is tubal factor infertility. HICOSI, as I said, is an ultrasound. So you put a very similar sort of device into the uterus. You can see the balloon on the left-hand side. You inject this dye, and you can see then that the dye is running into the pouch of Douglas, which would indicate the tubal patency. And you can do that right and left side. And a lap and dye test, as I said, you can see the blue dye in the image on the left. You can see there's tubal spill from the right tube, but not from the left. And as I said, male partner evaluation, I'm not going to touch on because I'm aware that I'm running out of time. But as I said, again, it's very important that you take a history from them, test the mainstay semen analysis, and if the semen analysis is normal, then that's nothing needs to be further done for the male. But if the semen analysis is abnormal, then you can go on and do a hormone profile, and if you've got azoospermia, you'll consider genetic testing. When you're doing a fertility assessment, ideally you want the couple to be seen together, but it is also important to give them time apart if there's something particularly they want to disclose without the other person knowing. Very important, this is an exceptionally stressful time. It's important to offer counselling to these patients, ensuring that all patients are on vitamin D and folic acid, making sure that you give advice for smoking and alcohol, and BMI optimisation. particularly in that first assessment. There's nothing worse than the patients, they do initial assessment, they come back with their results, and nobody has actually told her to address her BMI, and that she has to go away again, and which is very frustrating. The UK NHS IVF eligibility very much differs by region, which I find very frustrating, but it does, when we're looking at funding, it's important to think of what's going to make the most likely success. So a female's age, BMI are taken into consideration, duration of subfertility, any previous treatment. In England, if you have any children, you're not eligible for IVF, which and even if your partner has any children and you don't, in England, that means that the woman is not entitled to IVF, which I think is really unfair, but and smoking. And as I said, it very much is different from different regions. So Scotland are way ahead of the game. Everybody gets 3 cycles if you reach their eligibility criteria, and depending where you are in England, that can range between 1 and 3. Wales is 2 and Northern Ireland is 1. Sequelae of infertility. This is exceptionally distressing for couples and can put a lot of pressure on a relationship. Social stigma, particularly in developing countries. If you're found to be childless, as I said, it's a real a negative standpoint for your family. Financially, it can be devastating, particularly in countries where it's not funded. It can take a real toll on both male and female mental health, and it's a loss process for these patients. And as I said, financial burden is significant, particularly in low and middle income countries. You'll find that a cost of IVF can actually be more than an annual income. So we need to do more to be able to address this. Government policies need to ensure fair and accessible, high quality services that are affordable. So just to summarise, as I said, infertility, delay in conception for more than 12 months. It can be primary and secondary, can affect 1 in 6 couples. Age and lifestyle exposures are significant risk factors, and it's important that we do a timely, thorough assessment for these patients. And I'm happy to take any questions.
Okay, thank you very much, Emily, for such a comprehensive, overview of fertility and setting the scene. There are a couple of questions. Philippa, do you want to put the camera on, and if you want to ask quickly, otherwise I can ask on your behalf. Philippa Prizzini?
Oh, hi there. Sorry, I can't put the camera on at the moment.
No worries.
I was just asking. I just asked about the cesarean section as a factor for subfertility, because actually I was asked by one of my patients the other day during consent form, like routine consent form, and I was not aware of any research that can justify it as a factor for subfertility. That's why I asked.
Yeah, no, it's a great question. I actually have been asked the same question by a patient, because I'm still doing obstetrics and gynecology, and she was trying to consider whether she would do a maternal request cesarean section. And actually, there is literature that would suggest that in a patient who has had IVF and they have a cesarean section, that the chances of IVF working a second time around, there is I think that the chances of it decreasing is small, but it is definitely notable. So yes, the literature is there to say that there is. I'm not sure about a patient who's spontaneously conceived and go on to have a C-section, whether that can affect their fertility, but I know from an IVF standpoint that if you've had IVF before, it can reduce your chance of IVF again.
Thank you very much.
Okay, thank you. Rachel Roberts, would you like to ask your question?
Oh, hi. Can you hear me?
Yeah.
So thanks very much, Emily, for your talk. I was listening to the bit about smoking, and now that vaping is so popular, I wondered if you know what any of the guidance is, because we see that a lot in clinic, people who are vaping, and I just don't really know what the evidence is and what we should be telling our patients.
Another really good question. Thank you, Rachel. I actually don't know any specific studies. I think we can assume there's a lot of work that's coming out to say that from a health point of view, vaping is not good. Yes, it's better than smoking, but it's still not good, still causing significant chest issues. So from our patients, I never ask them about vaping, and it's not in our criteria. So I don't know whether, Jay, you know the answer to that, but I'm going to say vaping hasn't been around long enough, so we probably don't have that data yet, but I would suspect that it's ideally if you can advise your patient to stop vaping before trying to conceive. But that's not coming from anything that I know of concrete.
No, I agree, Emily. I mean, as far as I know as well, the data is limited, and there are quite a number of animal studies and things. But having said that, because the vaping contains nicotine, isn't it, and other chemicals as well, and that may have impact on the sperm factor as well as the fertility. And I think in our ICB, there are certain ICBs where they do specify, no smoking and no vaping, prior to embarking on IVF. Whereas in most ICBs, including ours, they don't specify. So as long as they are not smoking, they are eligible even if they are vaping. But having said that, the data is emerging, and the evidence is emerging that it could be affecting fertility, both in male and female.
Thank you very much.
There's one extension of the other question that Rachel has, the previous question that Sierra, okay. Would you like to ask? The question is niche, cesarean scar niche. What should we do, Emily?
Well, I would ask my boss, Professor Jay Prakash. Well, I think, as said, cesarean section scar niche. I think, I feel like I started training, 10 years ago, and we didn't know an awful lot about cesarean. It wasn't really a big thing, and I think we're increasingly picking up cesarean section scar niche, and it's trying to ascertain. There's probably millions of women across the world who have no issue with conceiving with the cesarean section scar niche, but when these women come to us, it's, as said, with infertility after having a cesarean section, as I said, there's not very many centres in the UK that are addressing cesarean section scar niche, and I suppose it has to be taken on a case-by-case basis. But if somebody who's previously not struggled to conceive and is now struggling to conceive with no other risk factors, then I think it's something we definitely have to consider.
Yeah, when I saw this question, I have added a couple of slides on my presentation, so I'll speak on that briefly. Yeah.
Perfect.
There's a comment by Greg. Greg, would you like to come in?
Yeah,
Greg Pearson.
Talk. Yeah, hello, hi, I'm Greg Pearson. I'm a consultant in Salisbury. Brilliant talk. Thank you very much. It's good to have an update. Just my question is, again, around caesarean sections, but also things like post-D and C. I see in my practice a fair number of people actually who have some intrauterine adhesions, and it's just something that interests me, because it's not something we classically are taught about or come across in presentations, and be wondering what your thoughts are on that. Thanks.
Yeah, so actually, very interestingly, this was actually brought to light to me quite recently, that the RCOG have, when you're looking at their patient information leaflets, looking at either manual vacuum aspirate for management of miscarriage or surgical management of miscarriage, that they are citing up to 15% risk of adhesions, and that's massive. That's and that can be really devastating. So it's just really important that we are educating patients coming through early pregnancy, and we're probably finding that many more are opting for medical management. But I think, as I said, if we're finding women who have previously had a normal menstrual cycle and have all of a sudden, they've amenorrhea or significantly lightened periods, then we do have to consider that they've got intrauterine adhesions, and a hysteroscopy can very quickly confirm that. Or, as said, you can do some ultrasounds with saline to ascertain whether there's any adhesions, depending on whether you have that access. But no, it's definitely something that the RCOG are increasing the awareness of.
Yeah, and I guess
Thanks,
the thing is as well, those of us that do obstetrics know that it might well be a risk factor for abnormal placentation, which is a whole different, not relevant for today, but a massive issue for those of us who practice across the specialty. Thank you very much.
Thank you. So I'm going to go ahead and will I go ahead and introduce Roger? Perfect. So our next speaker today, I'm very pleased to present to you, is Dr. Roger Stamworth, who is going to be talking today on hypogonadotrophic hypogonadism. Roger is a consultant endocrinologist in Derby and has been for 15 years, and his subspecialty interests include pituitary disorders and andrological endocrinology and gynae endocrinology. And we are very fortunate that he's been working alongside Professor Jay Prakash in the Derby Gynae Endocrine Clinic for the majority of his consultant career. And so we're very pleased that we've roped him in today to give a wonderful talk. So